Hello, my name is Dr. Bethany Murray. Today we'll be discussing core concepts in pharmacology. Specifically, I want to talk with you about pharmacokinetics and pharmacodynamics. Please bear with me just a moment while I set up our slide deck. Okay, there we go. All right, so pharmacokinetics is in chapter 4 in your e-text for this course. Our learning objectives for this chapter are to discuss the principles of pharmacokinetics, which include absorption, distribution, metabolism, and excretion of drugs. We want to look at the relationship briefly between age, gender, or disease, and how that alters pharmacokinetics. We want to briefly discuss genes and genotype and how that affects medication and drug metabolism specifically. I'd like you to understand the concept of first-pass liver metabolism and first-pass liver effects, and how some food or nutrients will affect drug and medication absorption and metabolism. Then lastly, understanding the concept of onset of action, peak action, and duration of action in terms of medications that people take. So what is pharmacokinetics? In essence, it's derived from the root words pharmaco, meaning medicine, and kinetics, meaning movement or motion. So simply put, you can think of pharmacokinetics is what the body does to a medication, a drug, or a toxin. Remember that anything that we ingest is interpreted by our bodies as a foreign substance or a toxin. Our bodies don't really recognize whether it is an illicit drug or alcohol or designed to be a therapeutic or beneficial agent. Our bodies just recognize this agent as something foreign, and it has to go through certain processes to be first absorbed, then distributed throughout the body, metabolized or broken down into its smaller components, and then excreted. So there are a lot of individual variables: age, biological sex, overall health, polypharmacy, comorbid health conditions, nutritional status, body weight, gene types, and pregnancy status, which will affect how our bodies absorb, distribute, metabolize, and excrete medications. So let's look briefly at this illustration. This shows us an example. We ingest a medication or a drug. It first goes into the stomach, where absorption will begin, but most absorption will actually happen further down into the small intestine. And then as the medications are absorbed through the stomach or the small intestine, they enter the bloodstream. The bloodstream will then carry the medication or substance to its desired target organs through the process of distribution. So distribution is highly dependent on cardiac status and vascular status, as well as plasma volume. So a person who is dehydrated will have a different distribution rate than a person who is overhydrated or perhaps retaining fluids. Then the medications will be carried through the bloodstream and into the venous system until they end up in the liver. The majority of metabolism of foreign products, including medications, occur in the liver. The liver will break these products down into smaller components that then go back through the bloodstream until they reach the kidneys, where they are then excreted to the outside of the body. And you'll also note over here at the large intestine that excretion also occurs through the feces and through the gastrointestinal system. So let's look at absorption a little more in depth. This is the process by which a substance will enter the body. So in healthcare and nursing, our routes for absorption include intravenous, sublingually or under the tongue, ocular or through the eyes, inhaled, either nasally or through a respiratory inhaler, intramuscularly, subcutaneously, subdermally, orally ingested, topically applied to the skin. There's just a myriad of ways that a substance can enter the body, and the route of that the substance takes will affect how quickly it becomes absorbed into the body. So in order for an oral drug, if we just look at medications by mouth, for an oral drug to be absorbed, it must be dissolved. And the rate of dissolution or dissolving of the drug depends on how quickly the drug will disintegrate and disperse into smaller forms. So this is the principle by which extended release or time release medications are designed. They are coded in such a way that the dissolution of the product is much, much slower, so that absorption either occurs more slowly or it is delayed until the product reaches the small intestine, where it's then absorbed into the bloodstream. So some medications are very rapid absorption, and some medications are more slowly absorbed. Bioavailability of a drug depends on the dosage form and how much of the medication will actually reach the target organ. So medication becomes absorbed through the gastrointestinal system, through the skin, or directly intravenously, and then it is passed through the liver. Some of it metabolizes, some of it goes on to be available to tissues. In absorption, medications have to cross plasma membranes. So plasma membranes are lipid, and anytime you see the word lipid, this means fatty acid or fat soluble. So they are lipid layers that contain proteins and other molecules. The first step in absorption is crossing over these lipid barriers. Large molecules may not be able to pass easily through these barriers. So they may need to have a little bit of extra assistance or push to get through a lipid barrier. So there are two means by which drugs can be passed through these lipid barriers. One is an active transport, where the product or chemical has to move against a concentration or a gradient, or some kind of effort is involved. So when we talk about protein-bound molecules, that's an example of an active transport where the medication is actually pulled through the membrane on in combination with a protein molecule that it binds to, and then that allows the medication to be absorbed more readily. Where there are lipid soluble medications that are pulled through because they are bind with fatty acid or lipid soluble molecules, and so they can get through the membranes, the plasma membranes, much more readily. The second type of absorption is diffusion or passive absorption, which is when a molecule is small enough to get through the lipid layer and just passively drifts, if you will, from an area of a higher concentration to an area of lower concentration. What are some of the factors then that affect absorption? So the formulation of the drug is one obvious factor. Liquids absorb faster than solids. IV is much faster than oral, which is faster than topical through the skin. Immediate release pills are faster than extended release. Higher doses of medication tend to absorb more quickly and act faster in the body. The size of the molecule, as I said earlier, small molecules may be more able to just passively drift through these plasma membranes, whereas larger molecules might need some kind of support. For surface area, if you're using a topical or a skin applied medication, the larger the surface area you cover, then the faster the absorption. Digestive motility can have an impact on absorption, as well as digestive pH or acid-base balance. Some drugs are more soluble in an acid environment, and some are more soluble in an alkaline environment. If you have a very active gastrointestinal tract, for example, people with irritable bowel syndrome that have a lot of diarrhea may absorb less medication because it passes through more quickly. Same thing occurs when someone has had a shortened gastrointestinal tract, for example, with gastric bypass surgery, where they just don't have as much stomach or maybe small intestine, or maybe someone that's had Crohn's disease and had to have part of their small intestine or large intestine removed. So any condition that shortens the gastrointestinal tract or that speeds up the passage of food and fluids through the GI tract will decrease absorption of medications. Greater blood flow to the site will increase absorption. So if you think about this, the medication must get from the outside of the world and absorbed and get into the bloodstream. So an area that's highly vascular will have a greater area of absorption than an area that is lacking in vascular structures. What are some of the areas that have less vascular structure? Well, the inner ear is a good example. The inner ear behind the tympanic membrane or eardrum is a very bony area. There's not a lot of blood flow inside that inner ear. It's difficult to get medications into that inner ear. You know, you can't use ear drops because they won't go through the tympanic membrane. So when you take an antibiotic, say for otitis media or an inner ear infection, you may have to take a larger dose for a longer period of time. Same things happens with sinus infections. The sinus cavities are open areas in the bone of the skull, and they're not very vascularized, so you don't get a lot of blood flow to those areas. So absorption of drugs is very poor in a sinus or a bony cavity. The reverse is true, though, if you're looking at an area that has a lot of blood flow. The liver, the kidneys, the heart, other organs in the body that are highly vascularized will have more absorption of drug, just as a matter of having more blood available to them. And then lastly, lipid-soluble drugs will absorb faster than water-soluble drugs. Even though our bodies are made up of, some people say over 95% water, we require water to survive, but yet our plasma membranes are made up of overlaying of fatty acids, and those are lipids. And so medications that dissolve better in lipids will be better absorbed into our bodies. And the same is true for nursing women who are breastfeeding. Lipid-soluble drugs will pass through the breast milk into the breast milk through the fatty acids that are contained in breast milk more readily. So a water-soluble medication will be less likely to be excreted in breast milk. So by now you should have some pretty good idea about factors that affect the absorption of medications. I mentioned pH of the stomach. Also, how much food has been eaten. Some medications are taken on an empty stomach because the presence of food or nutrients in the stomach will slow absorption. Some medications absorb better with a high-fat meal because of the lipid solubility of the diet. Some medications are bound to proteins and can be higher blood levels or lower blood levels, depending on the patient or the person's protein consumption. And then lastly, you can have medications that get bound up with nutrients. A classic example is the antibiotic tetracycline, which binds up with calcium and makes less tetracycline available. So you would need to know that you would never administer tetracycline with milk or dairy products, because you will not get the full dose of the medication if you do that. Tetracycline is best taken with something acidic like orange juice. Okay, so after absorption comes the concept of distribution. So distribution is just merely the physical movement of the molecule from where it's absorbed into the bloodstream to the target or the effector organ. So as I mentioned earlier, bony areas are much harder to deliver medication to because they have less blood flow. Lipid-soluble agents will get through the plasma barriers, and we'll talk about some of those barriers, a couple of those barriers in a minute. Some of your tissues can actually accumulate and store drugs after absorption, particularly if you're using an intramuscular, long-acting injectable. So some of those might be Depo-Provera for birth control management. Some of the chronic disease drugs, arthritis disease drugs, are given once a day, once a week, once a month. There are antipsychotics used in psychiatry that are given every 2 weeks, every month, every 6 weeks, and a few medications, one medication that's in even every 3 months. And all of these medications have to store themselves in the body in some way. So they typically store in the fat tissue surrounding the muscles. And then lastly, we think about distribution related to protein binding. Drugs that are highly protein bound will be more likely to be caught up in protein molecules, especially if a person is eating a high protein diet. And these protein molecules are too large to readily cross small capillary membranes and barriers. So a highly protein bound drug in a diet that has a lot of protein will actually reduce the availability of the drug to that target organ. So we can kind of look at this illustration to get a better understanding of that. So here's drug 1, which is highly protein bound. The P represents protein molecules in the patient's diet. So this highly protein bound drug gets caught up with these protein molecules and is less available then for a target organ. But if you look at drug 2, which is a loosely or a poorly protein-bound drug, it's not going to stick to those protein molecules or get bound up with those molecules. So there will be more drug available. So what if you have to take a highly protein-bound drug for a serious illness? It may be that the patient would be advised to eat less protein overall, or to take the drug at least 2 hours away from a protein-containing diet, so that the food and nutrients have time to have some digestion and move down into the gastrointestinal system. And the medication is taken basically on an empty stomach when there's no protein-based food in the system that will bind up and affect the distribution of the drug. Okay, so here's another example of this. Here are some free medication molecules. The P stands for protein molecules. The drug binds to, the highly protein-bound drug binds to the protein molecule. It's in the plasma. This middle bar represents a blood vessel. So the molecules are absorbed, they float around, they encounter some protein molecules, they attach and form this complex. The smaller molecules can get through the membrane, the lipid layer membrane, to the target organs or tissues, but the larger ones cannot. And so they continue on through the bloodstream and may eventually, they go to the liver, they're metabolized, and they may then become excreted in an unchanged form. Okay, another important concept is the idea of drug-to-drug interactions. If you go back to this previous and imagine, instead of this being protein molecules that you take, that the little blue beads are one medication and the orange P are a second medication. Medications can bind with one another, and that will affect their availability. There are basically 4 principles, 3 very important principles, and then 1 unknown principle of drug-to-drug interactions. The first one is addition. So when you take drug A and drug B together, you get the effects of drug A and the effects of drug B. So maybe an example of this is taking an antacid to reduce the production of acid, and then at the same time taking a medication that might coat the stomach or be protective on the inner lining of the stomach to help reduce ulcers. So the 2 medications both work to reduce acid formation and to prevent the development of ulcers. So they're added together in their benefit. A synergistic drug interaction actually means that the drugs, because of the way that they are metabolized, will make one another stronger. So if you take a drug that's a synergistic, it will result in a potentiated action. So one example I can think of this is the antidepressant fluoxetine, commonly known as Prozac, is synergistic with quite a few medications, including some anti-anxiety medications and also some high blood pressure medications. So if you've been taking fluoxetine for a number of months and then you add an antihypertensive medication, after about 2 weeks, when something called steady state is achieved, and steady state is when the blood level, the plasma level of the drug molecule is approximately steady. Metabolism matches absorption and distribution. So you're taking in about as much as you are metabolizing out and excreting out. Okay, so that's steady state. So after a few weeks of taking these 2 medications together that are synergistic, then the person experiences a low blood pressure crisis or a hypotensive crisis, because the fluoxetine is actually synergistic with an antihypertensive drug and causes the patient's blood pressure to drop more than it typically would be expected to drop. Okay? Sometimes in healthcare, those of us that are prescribers will know this and take advantage of this. So maybe a person has high blood pressure, they're on antihypertensives, they're poorly controlled, and they have an episode of depression or anxiety, and we're selecting an antidepressant, we might actually consciously think, well, if I use fluoxetine, I'm going to have the added benefit of lowering the blood pressure a little bit. Whereas if I use this other product that doesn't have this synergistic effect, it will not have any impact on the blood pressure. So that might be something you want, and it might be something you don't want. Antagonism is when you're taking one medication and it blocks the effects of a second medication. So it's good to know if drugs will be antagonistic with one another when you are when you have a patient who's taking multiple medications, because they may end up then not getting the benefits of one or both of the medications. And then lastly, the drugs may affect protein binding, those protein complexes, or some other effects within the body and alter the desired effect, but we don't really know or fully understand what the alteration is. And that would be displacement, if they're displacing protein molecules or displacing lipid-soluble medications. Okay, so there's a couple of unique plasma membrane barriers to keep in mind. One is the blood-brain barrier. This is a barrier in the vascular system that's designed to help protect our brains from toxic elements. And large molecules have a great deal of difficulty in crossing over into the brain. Small molecules might easily be able to cross over into the brain and have an effect. So any drug that is prescribed for a psychiatric reason must be able to cross the blood-brain barrier. So what's something that doesn't cross the blood-brain barrier? Well, maybe you can think of some products that we commonly take that don't affect your thinking or your mood or your feelings. Maybe something like Tums. If you're having an acid stomach, you might take Tums, but you don't feel the Tums mentally or in your brain. It stays only in the body. The Tums are calcium carbonate, and that's a very large molecule, and it's just not going to cross over and have any kind of significant impact as a medication in the brain. The other barrier that's really important to keep in mind is the fetal placental barrier. So substances may or may not be able to cross over from the placenta, and the vascular bloodstream of the pregnant woman feeds into the placenta. Then the placenta creates a barrier of what gets to the fetus and what doesn't get to the fetus. So some molecules may cross the placental barrier, and some molecules may not cross the placental barrier. So if it crosses over, then it will definitely cause effects on the developing fetus. And I've given you two examples here. Fetal alcohol syndrome, alcohol passes readily through the placenta. And in essence, a woman who is drinking on a regular basis during pregnancy is causing alcohol-related effects throughout development of the fetus, which we'll talk about when we talk about substance use disorder and fetal alcohol syndrome. But also any medication that the adult or the parent, the mother, could have psychiatric effects from or withdrawal effects from. So any kind of medication that you might have withdrawal from, an anxiety medication or a tranquilizer, a sleeping pill, or even antidepressants have some minor withdrawal, tobacco, nicotine withdrawal, and of course, opioids or pain pill withdrawal. Anything like that can cross the placental barrier, that infant will then be experiencing the same kind of withdrawal following birth. So if a medication must be taken for the health and well-being of the mother, then as much as possible, you want to be able to wean off this medication in at least a few days, if not a few weeks prior to birth, so that the neonate is not subjected to the necessity of withdrawing as a newborn. Okay, so the next thing to talk about is metabolism. Slide. Metabolism can sometimes be called biotransformation, and it's actually, in a nutshell, just taking a molecule and breaking it down into its smaller component parts. Some of those component parts might actually be the desired active ingredient for the target organs. Some of those component parts are just waste product, and they're eliminated directly by the body. So the molecule is chemically converted. Well, how does this happen? This happens predominantly in the liver. Probably 98, 99% of metabolism occurs in the liver. So first of all, you may be thinking, what about people with liver disease? And that's exactly right. If you have liver disease, your metabolism of products is impaired. People with liver disease of any kind are highly at risk for having toxic effects because of impaired metabolism of the drugs. In a healthy liver, though, we do have other things that impact metabolism. And one of those is the liver enzymes. So how are things metabolized by the liver? What is the magic, if you will, that occurs in the liver? Well, we have a number of enzymes in our liver that will act to break down these products. And I'll talk to you about enzymes in a little bit when we talk about pharmacodynamics. And everybody genetically has different levels and different activities of these liver enzymes. So all of us break down and metabolize medications at a different rate based on our own personal enzyme makeup in our livers. And then the last principle that I want you to be familiar with is something called the first pass effect. So if you go back to think about absorption and then distribution, the molecule is now in the bloodstream and it goes very rapidly through the venous system and into the liver where it's metabolized initially. So that first pass through the liver will break these molecules down into their component parts. And some of those parts will be active metabolites. And for some medications, the active metabolite is actually the desired treatment. And for other medications that don't have a lot of liver metabolism, it's because the medication itself is an active metabolite. And I can give you an example of that. There's an antidepressant called citalopram. It's not on your medication list, so I'm just using an example. Citalopram is the parent drug. S-citalopram, ES-citalopram, is the active metabolite. So you can prescribe Celexa or citalopram to a person, but what came on the market later was Lexapro, which is S-citalopram or the active metabolite. The benefit of taking Lexapro or S-citalopram is that it already has the first pass effect. It already has been predominantly metabolized into its smaller active components. So you don't get a lot of enzyme effects, variance between people based on genetics, or variance based on drug-to-drug interactions or enzyme inhibition or induction with things that are active metabolites. So there are a handful of drugs that we actually intentionally prescribe because they are active metabolites of the parent drug. Okay, so let's look at this illustration of metabolism again and a first pass effect. So here we have a person ingesting their daily medication. The oral drug is taken and represented by the blue beads into the stomach, into the small intestine, where it dissolves through the process of dissolution, becomes absorbed across the intestinal mucosa and into the blood system, the bloodstream. Eventually, it's going to make its way to the portal vein, into the venous system. It's going to be carried back up through the venous circulation into the liver, where these little yellow liver enzymes start to actively metabolize this drug. And on its first pass through the liver, the drug becomes metabolized to less active forms. These less active forms leave the liver and are excreted through the kidneys, but the more active metabolites are distributed to the tissues where they have their target desired effect. Okay, so I mentioned a little bit about genetics and liver enzymes. The predominant enzymes that we will talk about are called cytochrome P450 enzymes, or sometimes people just say P450 enzymes. And each medication has its own P450 enzyme profile. You can actually quickly Google that. I will just say, what's the P450 enzyme profile of lisinopril, say, that's a blood pressure medicine. And you can find that information out very quickly. It's highly metabolized by 2D6. It's a slow metabolized by 2C19. It's a rapid metabolized by 3A4 or 3A4 inducers. So sometimes things that are inducers, nicotine can be an inducer of enzyme inducer, which means it makes more enzymes. Grapefruit juice is an enzyme inhibitor. So grapefruit juice, when taken in the presence of many medications, will inhibit enzyme action and make the medication more potent or more strong, less is metabolized, so more is available for the target organs. Okay, so in a nutshell, these enzymes can be typical. They can be slow, very slow, intermediate slow, typical, rapid acting, or ultra rapid acting. So if you think of it this way, slower enzyme metabolizing means the medications are more available. They may not all break down in that first pass effect. It might take 2 or 3 rounds through the liver or even longer for them to break down. So that a person can become more toxic with the medication, and they may need a lower dose of the medication to avoid side effects. Whereas a rapid metabolizer, the enzymes are there's either more of them or they're very active enzymes. So the medication is rapidly broken down and excreted from the body. And this individual needs to have a higher dose of medications. And this is not dependent on age or gender. This is purely about your genetics. I have a case of a young boy I was taking care of, an 8-year-old for ADHD. He was very overactive, very inattentive, distractible. I kept titrating his ADHD, attention deficit disorder medication, up and up and up until I was almost double the FDA recommended dose. And he was better. He was significantly better and had no side effects. Then I was out of the country, and the manufacturer stopped making that formulation of ADHD medication, and he needed to be switched to a different formulation. But the on-call psychiatrist was not comfortable with the dosing regimen that this child was on because it was higher than what is recommended, and refused to prescribe the medication. So luckily it was over Christmas break, so he wasn't in school. It did have a significant impact on his behavior of going without his medication, but it didn't have as much of an impact on his schoolwork. When I came back, then I ran a gene assay test, and I was able to demonstrate that he was an ultra rapid metabolizer of that particular ADHD medication or stimulant medication. And this was why he was needing such significantly higher doses and not having side effects to the doses. So, once I was able to put that on the chart, I could justify why his dose of medication needed to be much higher than what would be typically prescribed. It's very difficult, though, if people there's a whole spattering of enzymes that we measure. I mentioned a few of them earlier. And it's very difficult when they have some that are slow and some that are rapid, some that are typical. Then it's hard to know what kind of effect the medication will have or the enzyme variation will have. But bottom line is, it's much better to prescribe medications with some kind of a genetic test, giving you some sense of predictability, than to just throw a dart at the wall and hope something sticks and hope that the medication you prescribe is going to work with minimal side effects. So we are very, very primitive in our use of gene assays in medication management. We are at the starting point in this sort of individualized patient-tailored care, but there are great strides being made in this field and a lot of exciting things going forward. So what are some other effects of metabolism? I mentioned inducers and inhibitors. So some drugs, some medications can increase metabolic activity of these enzymes and therefore metabolize other drugs more quickly and reduce plasma levels. That could be very problematic if maybe somebody is stabilized for a seizure disorder on an anti-epileptic drug, and then a provider prescribes a medication that is an enzyme inducer, and all of a sudden their anti-epileptic drug levels, serum levels, are lower and they have breakthrough seizures. Okay, so inducers will decrease the plasma level of susceptible drugs. And I say susceptible because it's not across the board all drugs are affected. You have to know which pathways or which enzymes those drugs are metabolized by. And then you can choose to use a different medication that will not be induced and have a lower plasma level. The reverse is also true. Some drugs and foods can be enzyme inhibitors, so they will slow down that metabolic activity. I gave you the example earlier of fluoxetine or Prozac and a blood pressure medicine, and therefore they will increase plasma levels of co-administered drugs. So then the person will have higher blood levels and be more likely to have adverse effects, side effects, even toxic effects. Okay. Another thing to think about is going back to liver health itself. Hepatic activity or liver activity is significantly reduced in infants and older adults. Older adults just normally through the aging process, all of our organs are less efficient. Notice I said our, not there, because I'm starting to reach the age where I start worrying about things like that. People with chronic liver disease or acute liver disease like cirrhosis of the liver, hepatitis, other kinds of liver infections, perhaps. And some chromosomal or genetic diseases of the liver will also affect metabolism. Okay, and then lastly, we get to the fourth pharmacokinetic property, and that's the property of excretion. So all substances eventually leave the body. If not, we could take one dose and be done. So our bodies will actively work to get everything out. Most excretion happens through the kidneys. Some substances can be excreted in the gastrointestinal tract or through sweat, tears, saliva, breast milk. Any fluids that can come out of the body can carry some substances out of the body. But for most medical purposes, we're predominantly concerned about the renal system and kidney function. Some drugs excrete faster if the environment is alkaline or acidic. So you can alkalinize the bloodstream with sodium bicarbonate intravenous fluids, not enough to cause disease, to cause harm to the patient, but you can slightly make a more alkaline environment if you need to excrete acidic drugs like aspirin more quickly if someone has maybe overdosed on that. Ammonium chloride is acidic, and given this will increase the excretion of other drugs such as diazepam or Valium. Sometimes we do prescribe, like for example, ammonia levels can become elevated in patients as a side effect of some drugs, and we'll prescribe lactulose, which is a high glucose concentration, and that will help to pull that ammonia out of the bloodstream. And it's an active transport plan, and it will pull that ammonia out of the bloodstream and allow it to be excreted more quickly in the renal tubules, so that people will have a lower ammonia level as a result. So having kidney disease has the most significant impact on excretion. You want to know if your older patient has healthy kidneys, or if they're in some stage, and there's typically 5 stages of kidney failure or kidney disease. And just like with the liver, if you have diseased or unhealthy kidneys, or you're lacking in kidneys in some way, and typically one healthy kidney will be fine. It will excrete drugs normally. But if you have some kind of renal failure or renal disease, then you may have to lower the dosages of medications because they may become toxic at the excretion level. Okay, so that was pharmacokinetics. So I know it's a lot getting into the science of these things now, but it's really important as nurses that you understand the principles of how a medication gets into the body, gets absorbed, gets distributed, gets metabolized, and gets excreted. And also that every medication that you give a patient will have its own unique characteristic properties of absorption, distribution, metabolism, and excretion. You don't have to know them all before you start practicing, but you should have enough familiarity, and you should know what you don't know. So if you're giving an unfamiliar drug, you need to look that drug up and understand its properties. So next, we're going to move on to chapter 5, which is pharmacodynamics. So we want to talk about therapeutic index, the difference between a lethal dose, a toxic dose, and an effective dose, the relationship between drugs and receptors, chemical receptors, or receptors at the cell level, and then talk about some of the terminology of how drugs work. So what is pharmacodynamics? It's basically the opposite of pharmacokinetics. Whereas pharmacokinetics is what does our body do to the drug, pharmacodynamics is what does the drug do to the body? How does this thing work? And so we spend a lot of time, and it's very important to me this semester that you understand the mechanism of action of the prototype drugs that we will be learning about this semester. The mechanism of action is basically another way of saying the pharmacodynamics. Is how does this drug work? What is it doing that's causing an effect in the body? If you understand the mechanism of action, if you understand the pharmacodynamics of this drug molecule, this medication, then you can apply that to all of the different uses. So medications are not prescribed just for one use. I'll give you an example of a medication called valproic acid. Brand name is Depakote. Valproic acid has at least 3 FDA-approved usages. One is it's an anti-epileptic. Secondly, it is approved for bipolar 1 disorder in psychiatric care. And thirdly, it's used preventatively as a migraine headache prevention medication. Okay, so by understanding the mechanism of action of how it inhibits the irritability of cells and slows sodium transport and then basically reduces the action potential and the firing of neurological cells, it's used to treat both seizures, mania, bipolar disorder, and to prevent migraine headaches. So that's just one, in a nutshell, example of where mechanism of action is very important. So what does a drug do to the body? How is this helpful for this specific patient? Why is this patient taking this drug? And then lastly, once you understand the mechanism of action, how a drug works, you can predict the kind of side effects or adverse effects that it might produce. So for example, the one I just told you about, valproic acid, it inhibits that sodium transport. It also increases a neurotransmitter called GABA, which is a sedative neurotransmitter. So we know its mechanism of action is going to make neurons less responsive, less irritable, less twitchy. And then you can predict that. So maybe one of the side effects of this product is actually sleepiness or drowsiness. And in fact, that's true. That is one of the major side effects, which could be good or bad, is drowsiness, because you've inhibited the neuron activity. Okay, let's move on. These are a couple of terms that you need to understand the definition, but also understand the principles behind it. So these are the onset of the drug, onset of action, the peak action, and the duration of action. So the onset is, when does it start working? We all know if we have a headache and we take acetaminophen or Tylenol, it doesn't work instantly. You have to wait 20 minutes or so, 20 to 30 minutes. That's the onset of action. Then the peak is, how strong is it when it's reached its peak in the highest concentration in the bloodstream? And that can be very important for toxic effects or side effects. Those are most likely to occur when the concentration in the bloodstream is at its highest level. And then the duration is, how long is it going to last? If you drink a cup of coffee, then your onset is probably about 10 to 15 minutes. You can feel the caffeine. Caffeine is a drug, right? The peak is about 2 hours. And then duration is about 4 to 6 hours, and then it wears off. So if you wanted to use coffee then therapeutically as a treatment agent, you couldn't just take it once a day. It's only going to last 6 hours. You would have to dose it every 6 hours. But we do know then that the side effect, because our mechanism of action is it's a sympathetic nervous system stimulator. So the side effect of caffeine or coffee is to stimulate the brain. So we wouldn't want to then take it at nighttime because it could interfere with sleep. So that's how these things kind of all fit together, right? This is why medications have different dosing frequencies. Some medications have a long duration. They can be taken once a day. A lot of blood pressure medicines are that way. Some medications have a very rapid onset, peak, and duration of action. And they have to be taken 2 to 3 times a day, or even 4 times a day. So here's an illustration of just these principles. Point 0 is when the medication is taken, and we're using oral, though this applies for all routes of administration. Things that are taken IV, which is the fastest route, will have a more rapid onset, almost immediately, more rapid peak, and more rapid, shorter duration of action. They'll get in fast, peak fast, and go out fast. Okay, but basically the arc, the curve is going to be the same across the board. You're going to have the medication absorb. It's going to have its clinical action. Then it's going to peak, where you will have more side effects. So you can see here, we're going to talk next about therapeutic range. So this range is when the medicine is working. But if it peaks too high, it could be toxic. Okay, and then it's going to start to be excreted. And when it hits this area where it's no longer within a therapeutic range, your duration of action is basically over, but it's still in your body. So you can see there's a termination of the action here, but the drug is still in the body until it's fully excreted. So in this example, they're using a single oral dose. It's given at 0.0 and it onsets in 2 hours. And the action kind of stops in 8 hours. And then it's completely metabolized out of the body, not until almost 12 hours later. So if I were going to prescribe this medication on a routine basis for a patient, I'm going to take this end tail of the curve into consideration and probably dose this just twice a day. So here at the 0 point, and then maybe again at this 6 hour point, because then we're going to get a similar curve, right? Like this. Okay. So a half-life, we often talk about a drug half-life. So this is the amount of time required for medications concentration to decrease by 50%. And so it's an easy way to talk about a long-acting drug has a longer half-life than a short-acting drug. So in this previous example, the half-life of the drug would probably be someplace, here's the peak plasma level, and then it starts to come down. So your half-life is probably hitting in this area someplace. Some drugs have a very, very quick, short half-life. Others have a very long. Some have days. I mentioned fluoxetine or Prozac earlier. It has a half-life of 36 to 48 hours. So it is going to be staying in the body. It's not going to necessarily have significant clinical effects, but it is going to be staying in the body before excretion for 36 to 48 hours. Why is there a difference between 36 and 48? Well, that's the individual patient's metabolic rate, their enzyme, liver metabolism, their age, the other factors that affect metabolism and excretion of a drug. Okay. So an aspirin, here's an example. Aspirin has a relatively short half-life, so it has to be given, if you're going to use it for something routine like blood clot prevention, every 3 to 4 hours. If the person has, again, any liver disease will decrease metabolism. Any kidney disease will decrease excretion. A long half-life drug is much more likely to become toxic in a patient with kidney or liver disease. Okay, so now we're going to talk about therapeutic index. This is going to get into a little bit of math, but bear with me. It's not, the math is only to help you understand the concepts. It is not a difficult principle to really grasp. So a drug's median, which is the halfway, the middle effective dose, ED50, is the dose required to produce a response in the research trials in 50% of patients. Okay, so if you look at this graph, you've got number of patients responding, okay, and then you hit 200 people or 50%, that's 50% of the people hit right here. Okay, so that's called the ED50. Okay. The lethal dose is the medication that is lethal in 50% of animals in drug trials. Okay, so we don't give lethal doses to humans in drug trials for obvious reasons. But if you're involved in pharmaceutical studies, you will, in developing new pharmaceutical agents, you will administer these to rats or mice or chimpanzees, to animals, and measure the dosing and count at what level a dose becomes toxic and the animal dies. The lethal dose, the LD50, is the dose that will kill half the animals in research trials. So a therapeutic index is actually a mathematical formula, which is the lethal dose as determined by animal trials, divided by the effective, the middle effective dose. So the dose that's effective, the dose that kills 50% of research participants, divided by the dose that is effective in 50%. Okay, so this is called the therapeutic index, and it's a measure of a drug's safety margin. We do not want to prescribe a drug that has that's lethal to people, right? So the higher the value, the greater the mathematical formula or value, the safer the drug is. So what is a T1? I'll just ask you this as a challenge question. Think about that a minute. So if the therapeutic index is 1, that means that the lethal dose is the same as the effective dose. So the lethal dose is, say, 20 milligrams, and the effective dose is 20 milligrams. So it doesn't become effective for a person until it becomes lethal in half of the people. Okay. So is that a drug that you would want to take? I would hope not, because that's a really scary drug. However, some of our chemotherapy drugs, they're not one, but they will approach lower numbers. And that's because in order to kill cancer cells, sometimes you kill healthy human cells as well. So some drugs that are very high risk will have very narrow therapeutic indices. Okay, so just kind of keep that in mind. We want a drug to have a really big number because that means it has a really wide therapeutic index. It's a very safe drug. If it has a very small number, it has a very narrow therapeutic index. And so if we're prescribing that drug, we might monitor blood levels of the drug a lot. A drug that I'm not asking you to learn this year in psychiatry is lithium carbonate. It's prescribed for bipolar disorder. It has a therapeutic index, or it has a range of 0.1 to 1.5. Any dose under 0.5 to 1.5. Any dose under 0.5 is not therapeutic. It's not going to reach that 50% of the people. Any dose over 1.5 becomes toxic. You get above 3 and you start becoming lethal toxic. You start developing acute renal failure. So it's got a very narrow. So how do we accommodate for that? Because it's a very effective medication. We account for that by drawing blood levels. And we keep that blood level, that lithium serum level in the plasma within that therapeutic index range. And if it starts to creep up too high, we reduce the dosage. Okay. Okay, so because we can't really determine the lethal dose in humans, in human trials, researchers will use a median toxicity dose. And so it is a proxy for a lethal dose. So a toxic dose in 50% of people, this represents toxic dose in 50% of people divided by an effective dose in 50% of the people. Any number then over 10 is considered safe for use in human beings. Okay. So let me show you these two tables. Which drug would you determine to be more lethal? Drug X on your left or drug Z on your right? Okay. Well, you can look at this table in two ways. First of all, you can look at the math. The lethal dose over the effective dose. 40 is the lethal dose, 10 is the effective. You get you get a number of 4. Whereas on the right, you get a number of 2. So clearly, the smaller the number, the less range you have, and the more lethal the drug, the more dangerous the drug is. So clearly, just looking at the math, drug Z is more lethal. But if you look at the graphs, this also tells us the same thing. This effective dose is way down here at 10, whereas this lethal dose is way up here at 40, and they don't overlap. There are no patients in this trial, or no research subjects in this trial, that receive an effective dose that is also lethal. However, in this drug trial, where all the points are plotted on this graph, you have, if people or research participants receive an effective dose that also crosses into the lethal dose territory. Okay, so there's two ways to look at this, and we can clearly see then that drug Z is significantly more dangerous than drug X. Okay, drug dosage and blood concentration. So as a medication drug level increases in the body, then there is a positive correlation with side effects or adverse effects. So the more peak concentration you have, the more likely you will have side effects to a medication. And I mentioned earlier that we might draw blood levels in the lab to try to help keep our medication within that therapeutic range, and as low as possible within that therapeutic range. Because even though the effective dose is 50% of the people, that means that almost half of the people can have an effective benefit, a clinical benefit, at a lower dosage of medication. Okay, so drugs will act by modulating or changing existing physiological and biochemical processes. when you take a medication, it doesn't do anything by itself. It has to act on something in the body and change something in the body to have an activity. Okay, so the majority of medications will then bind with receptors in the body, and these receptors are made up of protein cells. So remember, lipid cells to get through the plasma membrane, that's lipid, but now we're getting into receptors at a microscope level, which are made of protein cells. And the channels to get into the cells themselves are can be triggered to allow a drug to enter the cell. So we talked at a macro level of getting the medication from the bloodstream to the organ. We've gotten to the organ, but now we need to get into the cells. So if you think about maybe an antibiotic, what cells does it need to get into? It needs to get into the cells of the bacterium, right? So we have to act on the bacterial wall cells to get into the bacterial cells. So every medication has to act on a receptor on a cell in order to have an effect, or else it just floats around there and doesn't actually have any action and is then excreted. So there are two major kinds of receptor channels. Actually, I'm going to show you 4 on the next slide, but there's 2 I want you to think about because they're very important to the medications we'll be learning about this semester. First is things that have a positive or a negative charge. These are called voltage-gated channels. They open up the cell wall. They open up a channel into the cell using electrolytes. So you thought physiology would never need to think about physiology again. Hopefully some of you have had chemistry in high school, and maybe you thought you were never going to have to think about the chemical tables, the table of elements, and positive charges and negative charges, but you were wrong because these are very important for voltage-gated channels, especially if you think about cardiac care. How do the cardiac cells fire an impulse? They do that through positively charged ions. Sodium and potassium trade places, then calcium comes in, and magnesium is very involved in muscle contractions. So we get drugs into cells because they can act on these positively charged ions and negatively charged ions and electrolytes to open the cell door, open the door, if you will. The second way, and this is particularly important for the nervous system, is that medications will act on neurotransmitters that then will open up channels into the neuron or the nerve cells. Okay, so this illustration shows you 4. These top 2 are what I was just talking about. So a voltage-gated channel using sodium, potassium, calcium to basically open up a pathway into a cell. And then chemical-gated channel, where you use chemical neurotransmitters in the body to open up a passage into the cell. And then here at the bottom, we have a G protein link channel and a complex ion channel, but we're not gonna go that deep into this concept. I think if we can just grasp these 2, this is pretty good for this semester. Okay, so what are some of the actions that these medications or drugs will have on those cell receptors? Remember, there are receptors. Let me go back again. Something receives. Here we have a little example. It's receiving the medication. These are receptor sites. Well, receptors can be agonized, and the word agonist means to mimic, imitate, or turn on, like flipping a switch on. They can activate the cell, or the medication might antagonize, jump down here to the bottom. And antagonize means to compete with, to replace, to prevent the natural action, or turn off the cell. Okay, turn off some activity. And then you can also have a partial agonist where there's a weak binding. I think learning about agonist and the term agonism and antagonism is extremely important. So here's an example. Morphine, it's an opiate drug. It's an endorphin. Endorphins are natural neurotransmitters that we have in our bodies. Morphine is an endorphin receptor agonist. Okay, so it agonizes, it mimics a natural endorphin for pain relief. It's a very potent, very powerful endorphin agonist. And we'll talk a lot about atropine and acetylcholine when we get into the nervous system. So for now, just know that we also have medications like atropine that then will block or antagonize or prevent an action of a cell. Okay. And some cells are affected by enzymes. So I want you to think about enzymes as being helper molecules. They are natural chemicals in the body that help speed up chemical reactions. So you might remember this from physiology or from chemistry. Enzymes speed up chemical reactions in our body. Okay. And they're not the same. I mean, they are like liver enzymes are enzymes, right? The cytochrome P450 enzymes are enzymes that are speeding up or slowing down metabolism of drugs. But we have other enzymes in our body. We have enzymes in the nervous system, in the bloodstream. We have a lot of enzymes. One really nice, helpful thing is that an enzyme almost always ends with this, what you see here at the bottom, ACE at the end. So esterase is an enzyme of esters of different times. So you can almost always identify an enzyme in medical terminology because it ends without that suffix of ASE. So every cell in the human body contains thousands of enzymes. These enzymes help facilitate chemical reactions. Enzymes are usually not degraded, so they can be used over and over and over again. If they are degraded, it's a disease process. Okay, so some of the drugs we use will inhibit the action of an enzyme. And when they inhibit the action of an enzyme, they slow down that natural chemical process. So in essence, we have three ways that medications will act once they get to their receptor site. They will agonize or turn on the receptors for the cell receptor sites. They will antagonize or turn off, or they will muck around with the enzymes and affect the enzymes of the cell and either speed them up or slow them down. And most of the time they slow them down. Okay, let me give you this complicated example and I'll break it down for you. Acetylcholine is a neurotransmitter in the body, in the parasympathetic nervous system. You're going to learn a lot about that with parasympathetic nervous system. So acetylcholine is a natural occurring parasympathetic nervous system chemical neurotransmitter. It is broken down by acetylcholine esterase. That's its enzyme. Okay. So if we want to increase acetylcholine in the brain in particular, a medication that inhibits that enzyme is called donepezil, and it's prescribed for Alzheimer's dementia. It inhibits the enzyme that breaks down acetylcholine. So therefore, the person has more acetylcholine in their brain. Okay, so it's complicated, but if you just think it through step by step, it's actually quite simple and very logical. Okay, I want to have you look at a couple of practice questions. One aspect of pharmacotherapeutics is the study of the clinical indications of drug therapy. Okay, so we talked about pharmacokinetics, which is what the body does to the drug. We talked about pharmacodynamics, which is what the drug does to the body, or how does it work. And then pharmacotherapeutics is how do we use it? Okay, so the clinical application. So that means that this question is actually true. It's a study of the desired therapeutic benefit or clinical benefit of the medication. All drugs have some kind of adverse side effect. That's true. Can you take any medication and not have a chance of a side effect? Can you take a vitamin and not get sick to your stomach? And some people say they have no side effects, but every medication has the risk of having some kind of a side effect. Okay. Okay, here's a little bit harder. What will be the result of giving a highly protein-bound drug? And remember that cartoon of little blue beaded drugs and all the P's, the protein molecules, in a person with liver failure. Highly protein-bound drug in a person with liver failure. So they do not metabolize the drugs effectively. Okay, is it not going to make any difference? Well, that's probably not true because of the liver failure. Is it going to reach the target cells more quickly? Is it going to reach the target cells more quickly, which will result in a toxic effect? So if you reach them more quickly, is that going to be a decreased benefit? Is it going to be a toxic benefit? Or is it going to reach the target cells more slowly if you have a highly protein-bound drug with liver failure. And in fact, the person does not metabolize the medications, the molecule well, so it's going to reach the target cells more quickly, which could result in a toxic effect. Okay, patients with liver failure have lower levels of protein and albumin in their blood than patients without liver failure. That means that protein-bound drug is looking for protein and can't find it. Okay, so it's not binding with protein molecules, so there will be more drug available floating around that will reach the target cells more quickly, which could lead to a toxic effect. Any liver disease puts a person at risk for a toxic effect. All recommended drug dosages are calculated in research trials on a person, a healthy young adult with normal protein levels and normal liver functioning. Okay, so I've given you a lot today. As far as your homework for this week, I'd like you to play around a little bit with Top Hat on your own. I've created assigned homework, just 7 questions on pharmacodynamics and pharmacokinetics. I can go in later and see if you have completed your homework. There's no points assigned to this. It's just sort of a completion, non-completion assignment, so you can help practice. Okay. So tophat.com, the join code is 000557, and then you should be able to find under B261 pharmacology assigned homework and 7 questions. And then secondly, you also have an open book quiz, 20-point quiz, just like the quiz that we did on medication abbreviations. It is take your time. There's no time limit. You can use any resources. You can look things up on the net. You can do it with a friend. You can sit in a small group and do this together. However you would like to do that. It's open book. But once you choose an answer, I'm trying to emphasize that students are confident in their responses and don't obsess and dwell over. So once you decide what your answer is and move forward, you can't go back and retake it. You can't change your answer. Okay. And that one is a graded assignment as part of your homework grade for the course. All right, thank you very much for your attention. I know this was probably a fairly long video for you. It is replacing class this week because of the holiday week. And if you have any questions on pharmacokinetics, pharmacodynamics, or any of the principles that I talked about today, please use the Inscribe Q&A discussion tab on your Canvas site. That puts the question, you can post it anonymously, but it puts it out there publicly for the entire class to see, and then I can respond to that for the entire class. That is much preferable to emailing me or asking me individual questions when it's about content. Okay, thank you very much, and I appreciate your time, and I look forward to seeing you again in class.